So my name is Idoroenyi Amanam. I'm a hematologist oncologist, specializes in bone marrow transplant at City of Hope National Medical Center in Duarte, California. So real-world studies are really important, and I think for for providers in the community, I think there are instances where they look at phase 3 clinical trials and they don't feel that the population that they see mirrors what we're seeing in these phase 3 trials. And so I think it is important to collect additional data after a robust phase 3 study that I would say essentially recapitulates what we've learned from that phase 3 study, but in a population or an environment that may be potentially different. And these real-world studies do that. I think when we think about low-risk MDS patients, these patients are, especially if they're transfusion dependent, these patients have potentially a poor quality of life. They have to go to either an infusion center, an emergency room. They may have to wait for a day or two to receive a transfusion, and that takes time. So if you're requiring a transfusion once a week, and it takes 2 days to get a transfusion, that's 2 days out of your week where you're sitting in a hospital or you're getting poked. And so I think having the opportunity to be able to reduce that burden on patients and also the hospital systems is great, and Luspatercept offers that. So Luspatercept has a unique mechanism of action that's very different from ESAs, and I think because of that, that's the reason that Luspatercept has a faster response and also a much more durable response, and also gives patients a greater opportunity to become transfusion independent. I think that's a great question. I would maybe push back to say that, you think about RS positivity in a Luspatercept cohort, that actually confers to the way that we think about a better, a biologically and potentially a better response. And so having less RS positive patients and showing that you had even a greater response compared to ESAs, I think really proves that Luspatercept is the better therapy for these low-risk MDS patients. I think the take-home is that, the COMMAND study was very important for us in low-risk MDS. I think we haven't had too many therapies available for these patients, and this real-world study kind of reconfirms or supports what we've learned from COMMANDs. And so Luspatercept is the drug that we should be using in these low-risk MDS patients. We should be thinking about our low-risk MDS patients in terms of their transfusion burden, their quality of life, and I believe Luspatercept gives an opportunity for these patients to have an improvement in that area.